I am pleased to introduce you Dr. James Good, radiation oncologist in GenesisCare UK based in Oxford, and who is talking about, he's going to host the second session about GI tumors with MRI-guided radiotherapy. Thank you, James.
Thank you, Vlad, and what a joy it is to finally have a face-to-face meeting, especially in such a beautiful city after a long period of enforced absence from each other's company. So we've got a cracking lineup of speakers this afternoon on the exciting world of GI cancer. In a slight change to the running order, we're going to start off with Dr. Michael Chong. Mike leads the MR-guided radiotherapy and proton therapy GI program at Miami Cancer Institute. He is really a leading light in the world of pancreatic cancer and has coordinated and led research that is really beginning now to change the game in this disease. He is going to be speaking to us this afternoon about that program and that experience. For those of you dialing in from online, please do not hold back in entering questions into the web portal so that we can put those to Mike at the end of his talk, because I understand he has to run off at the end of it to attend to some clinical matters. So please get those questions in at the end, and I'm going to hand over now to Mike.
Hi, good morning, good afternoon from sunny Miami, and thanks so much for the invitation to participate today to the organizers. And so I wish I could be there in person. I actually will be in Copenhagen in a few days and look forward to seeing some of you in person. I don't see my slides yet, so I'm going to wait for that. Here we go. And I think my understanding is that the slides will be advanced for me. So if that's the case, then we'll go ahead. But just as a preface, the world of pancreas cancer in terms of radiotherapy applications really is expanding, as many of you know. And it's really through technology such as MRIdian that allow us to transcend what has historically been safe and also effective. So next slide, please. Next slide, please. Next slide, please. So these are my disclosures. Next slide, please. So just by way of brief outline, just want to give the audience a brief overview of our institution and how we utilize MRIdian, especially for pancreas cancer. And as you can see here, just a brief overview of pancreas cancer and also how ablative radiation therapy is transforming the field. Next slide, please. So Miami Cancer Institute, just very briefly, is a relatively new institution as part of the Baptist Health South Florida healthcare system, which is the largest provider of healthcare in South Florida. And you can see here that we're only just shy of, or just greater than 5 years old, but a lot has happened in that period of time. Next slide, please. And one of the next slide, please. And so one of the unique aspects that you'll see on the next slide is that we have a number of state-of-the-art technologies, including proton therapy as well as MRIdian, and we were the second institution in the United States to begin treating with the V-Ray MRIdian Linac. Next slide. And here you can see just a very quick snapshot of the technologies that we offer and uniquely offer all under the same roof within the same building. So it is easy for us to be able to switch patients from one to the other and able to deliver hybrid, for example, technology type of treatments, for example, a combination of proton therapy and MR-guided radiotherapy. Next slide, please. So there are many animations in my slides, so you can advance. If there's a way for me to control the slides, it will go much quicker, but yeah, you can. Just very quickly, pancreas cancer, we of course know is a deadly disease. Most patients are unresectable at diagnosis. And while radiotherapy we know is beneficial in terms of local control, it certainly is controversial in terms of survival benefit, as well as for other applications such as resectable pancreas cancer and increasingly borderline resectable disease. And the focus of the presentation here will be mostly on locally advanced disease. Next slide. And of course, the fundamental challenge that we have within the radiotherapy community for treating pancreas cancers is that the GI organs at risk, which many times abut, if not are in close proximity, are dose limiting. And the dose concerns really are a non-ablative type of dose. Next slide, please. However, there's of course been recent focus on the benefits of dose escalation to an ablative range, and that in many ways has been led by Dr. Crane, who is now at MSK. And next slide, please. If you look at the definition of ablative, what is that in the dictionary? And that actually refers to the surgical removal or having surgical intent. And I think that's really the exciting part of how we are potentially transforming the field of radiotherapy for pancreas cancer, and that outcomes to date seem to be reaching that point where maybe we're affecting patients in a positive way, even to the point of maybe reaching outcomes that are in the realm of what surgical resection might achieve. And of course, we're a ways off from proving that, but at least the outcomes so far are very exciting in that regard. Next slide, please. But of course, we know that delivering ablative radiation can cause toxicity, and that is really the fundamental challenge, in that we know that ablative dose is something that we want to deliver to tumor, but how do we do so safely? Next slide, please. And there are, I think, good data for us to understand that there is an importance in minimizing dose to structures, despite wanting to deliver ablative dose. This is now a bit of an older phase 2 trial from Hoyer and colleagues, in which an ablative dose was prescribed in 3 fractions, yet the imaging was portal imaging. There were relatively large margins. And you can see here that the toxicities were not trivial. And in fact, the authors noted that the acute toxicities were in fact pronounced, where 2/3 of patients had grade 3 nausea, diarrhea, and pain. So I think this is an important lesson for us to learn that it's not just an ablative dose we need to focus on, but it's also how do we deliver that safely? Next slide, please. And again, the dose fractionation constraints, at least in 5 fractions, this audience I'm sure is well aware, but just to drive home the point, we're looking typically in 5 fractions of maximum doses or doses to 0.5 cc in the 30 to low 30 gray range. Yet, many of us are now trying to deliver doses, for example, of 50 gram 5 fractions to target that is, again, abutting or near these critical structures. Next slide, please. And just to, again, drive from the point that non-ablative pancreas cancer still is very much the standard of care and routine. This is an analysis from the National Cancer Database of over 14,000 patients, over 2,000 who received SBRT. And you can see, not surprisingly, that the median dose is a non-ablative one. So a median BED10 of 60 gray. So this is obviously the, this is the standard of care as of today. Next slide, please. And we know that doses delivered with non-ablative intent, the outcomes are not particularly great. And so with or without radiotherapy, that is non-ablative. If you look at chemotherapy outcomes alone, or non-ablative radiation outcomes in addition, the long-term survival is very poor. So I think the data consistently demonstrate 2-year survival numbers in the 20 to maybe 25% range. And that, of course, needs to improve. Next slide, please. And the non-ablative radiation, next slide, please. And the non-ablative radiation outcomes, either with standard fractionation, for example, from LAP07, as well as with 5 fraction SBRT, are really strikingly similar, again, in that range of about 20 to 23, 25%. And that number and those numbers are reproducible throughout the literature. Next slide, please. And I would actually note that is also the same with modern multi-agent chemotherapy. The high-tech manuscript and this publication within the high-tech publications, I think, drive home the point that dose matters, and dose for locally advanced patients who do not undergo resection is significantly associated with local control. And so therefore, the question would be, is delivering an ablative dose here to improve local control meaningful for patients with local advanced disease? Next slide, please. There are, I think, precedent data, and this paper from Christian and colleagues and Chris Crane's group when he was at MD Anderson, I think, got a lot of us thinking about, can we deliver ablative dose, and does that actually improve outcomes in addition to local control? And this was, now a little bit of an older study using CT guidance and with significant, with a significantly prolonged fractionation schedule compared to what we've been doing with 5 fractions. But nonetheless, at least it got us thinking that perhaps 2-year survival could be significantly improved with dose escalation. Next slide, please. And I think a critical point here is that deaths from pancreas cancer are, of course, due to metastatic disease in patients who do have distant metastases, but even local progression is a cause of morbidity and mortality. And I think that's underestimated and underappreciated in many cases. And this actually applies to patients who have distant metastatic disease. And in fact, this is now one of the seminal papers, I think, in the field from the Hopkins group, from a rapid autopsy study that demonstrated 1/3 of deaths were due to local progression, for example, causing obstruction or cholangitis or bleeding. And this is with or without distant metastases. And therefore, next slide, please. The question would be, could delaying or preventing local progression with ablative radiation dose impact overall survival? Now, what are the obstacles to delivering ablative dose? There are many animations, so you can just kind of scroll through this. But of course, soft tissue resolution with CT is limited. There is no intrafraction imaging with standard Linacs. There's respiratory motion, and rapid online planet adaptation is not widely available as of today with CT guidance. Next slide, please. And so the solution to that, at least what we've adopted here, has been MRIdian, and that an ablative dose can be delivered and is delivered, at least at our institution, for any tumor, whether in the chest, abdomen, or pelvis, and that is with regard to whether bowel or stomach is abutting or not. And so this is truly an ablative option for a wide variety of patients, including pancreas cancer. But the reasons that you see listed here, I think, are not foreign to anybody in this audience, in that there's superior soft tissue visualization, continuous intrafraction imaging, soft tissue tracking, automatic beam triggering, and the automatic beam triggering is uniquely available only on the MRIdian system, as opposed to other MR solutions. And of course, there's daily online adaptive replanning. Next slide, please. And I would argue that all four of these are critical to achieving safe dose escalation, especially with an ablative dose delivered to the majority of the target. You know, I think it's common to prescribe ablative doses with other systems. Yet, if you look at the coverage of the GTV and PTV, it may not be as optimal as you'd like, and we're able to optimize that with MRIdian for sure. So let's go through a case quickly. This is a typical 60-something-year-old patient with a locally advanced tumor who received induction FOLFIRINOX and then had stable disease. Next slide, please. So this patient came to us. Actually, I'm not there in the audience, but if you know, I always like to get the audience's opinion about how you would treat. But you know, many times it's a non-ablative option that's preferred. Next slide, please. So of course, MRI improves daily image guidance. And if you advance, you'll see this is the same patient treated at our institution with MBCT versus, can you advance, please? Versus MR. And I would just highlight that we are not, and I haven't used contrast, either PO or IV for these patients since we started treating in 2018. So it's really nice for patients, and the soft tissue contrast is really quite tremendous with MRIdian. Next slide, please. Of course, the segmentation is done on the MR, which is the primary scan. Next slide, please. You'll notice that both arms are down, which has been our standard approach for a number of years now. In terms of the treatment planning for this patient and other patients, our routine since really early 2019 has been to treat not just GTV, but also elective volumes. And typically what I've been treating is a volume or a margin around the celiac axis SMA and also the primary tumor itself. And that typically consists of a 5 mm radial margin of all of those and the proximal 2 to 3 centimeter extent of the vascular structures at a minimum. And just for reference, this is an editorial that I put together with Jordan Carofa and Nina Sanford that was published in Red Journal recently, presenting an argument for why we should think about elective coverage more as a standard option. Next slide, please. So we just really quickly in terms of how we plan. So we use a 3 mm margin around the GI OARs to create a PRV. Next slide. We then create an optimization structure so that the overlap of the PTV by the GI OAR is carved out. So that becomes our optimization PTV. Next slide. There is then a GTV opti structure that's created as well. Next slide, please. There is a core structure. So essentially this drives the hotspot. So it's a contraction of the GTV optimization structure by 3 to 5 millimeters. And this is what drives the hotspot. So all of our plans will have a minimum of 120% of prescription, but we aim to get up to 130 or 140 if feasible. Next slide, please. And the key here is, of course, driving the hotspot to be within the core of the tumor and not within GI OARs. We prioritize conformality of both high dose and low dose. So you can see the 50% confined within the 2 centimeter ring. Next slide, please. These are dose constraints just for reference that we published in 2020 in our initial clinical outcomes paper in practical radiation oncology. You'll note that the dose constraints are a little bit more aggressive than it would have been published in prior series. So these honestly were, I kind of took what was out there before and figured if we have MR guidance to ensure that the doses are what we think they will be delivered to each day, we probably can get a little bit more aggressive with the constraints to allow for better target coverage. So far, these constraints have not yielded significant toxicity in the vast majority of patients. Next slide, please. Is there a way for me to advance the slides? Because there's many more, and I know we're running out of time. There's not. Okay. So with that being said, so this is just quickly is how this is one of our patients being set up. Next slide. And just for the sake of time, I'm just going to advance through these slides and get to some of the data. So this is an MR to MR match each day. It's we can go to the next slide. And then we contour within a 3 centimeter expansion of the PTV and then 2 cranial to caudal. Next slide, please. Next slide, please. And I'm just going to advance the ability to perform online adaptation. I think should be pretty well understood by this audience, but of course, for these tumors in particular that are surrounded by GI OARs, we are almost needing to adapt almost every single day. So I think 99% of our pancreas fractions at 55 have needed to be adapted because of either stomach duodenum or small bowel constraints being violated. Next slide, please. And I would actually highlight, with the ability to provide adaptation, our typical PTV coverage by the prescription dose is somewhere typically in the, I would say, mid 70% range in GTV by the 50 gray. Isodose probably in the low 90% range. So actually the vast majority of tumor does receive an ablative prescription dose. Next slide, please. Next slide. And this is a figure, actually, our more recent institutional outcomes have been just recently accepted for publication, and this is a figure from that. But basically, we looked at our adapted fractions in terms of the predicted dose before adaptation and also what we achieved with adaptation. And you can see in the blue, clearly we would have violated the constraints considerably without being able to adapt. And with online adaptive replanning, every single fraction was met in terms of the OAR sparing. So I think it's a nice visual representation of the dramatic difference here with the ability to adapt. Next slide, please. We do have a monitor in the room, like many other institutions, for visual biofeedback, which significantly improves the patient experience and also improves treatment efficiency. Next slide, please. This, of course, is the Cine MRI that we see during treatment that provides the automatic beam gating, and this is a significant, I think, component to minimizing, OAR dose. Next slide, please. Sorry, I'm rushing through some of this just for the sake of time. At our institution, this is just one snapshot of one patient over 5 fractions, but to give the audience a sense of the time it's taking at MCI, it's typically about 60 minutes door to door. The treatment time is somewhere in the 12 to 13 minute range, typically with the beam pause due to respiration. You can see here that the other components, the times listed here. Next slide, please. Of course, A3i is an exciting development within the V-Ray ecosphere. And just from seeing what I've seen, a little bit of a preview, I think 30 to maybe 40 minute adaptive times for a 10 gray fraction like a pancreas case will become probably routine in the near future. Next slide, please. Of course, there are exciting data. The Ruger paper, I think, is known by many, if not everyone in the audience, in terms of being really the first MR-based analysis to suggest that survival could be improved through dose escalation. Next slide. And here are the Kaplan-Meier plots to demonstrate that. So 2-year survival of almost 50% versus 30%. Next slide, please. This was our initial institutional outcomes from MCI. It was a relatively small series of 35 patients treated mostly with 50 gray and 5 fractions. But I think the exciting conclusions here were, one, the early efficacy was very good, but we did not see any major toxicities in terms of grade 3 or higher, really at less than 5%. The table on the bottom right, I would just highlight in that, I wanted to include this just to drive home the point that we're not just delivering we're not just prescribing an ablative dose and delivering it to a small part of the target. And for reference, if you wanted to look at this later, the vast majority of target does receive ablative prescription dose, which is very unique, and I think does probably impact long-term clinical efficacy. Next slide, please. We had an updated analysis that I presented at ESTRO last year of 50 patients with longer follow-up, so 18 months median, most with locally advanced disease, most who received induction chemotherapy. And again, we saw very excitingly that survival in these patients was right around 50% when compared to the historical 20 to 25%, represents a potential doubling in long-term survival. Next slide, please. We also combined our data with data from Achi Bottom and also Henry Ford colleagues. This was presented at ASTRO last year of almost 150 patients, most with locally advanced disease, but some with borderline resectable and medically inoperable disease. Median dose was 50 and 5. Again, most patients received chemotherapy up front. Next slide, please. You can see the numbers here. I would just highlight that local control at 2 years was 83%, which is certainly favorable compared to non-ablative historical numbers. And the survival numbers, of course, are very exciting. Again, in the realm of surgical outcomes at median survival of 26 months and 2-year survival exceeding 50%. Next slide, please. Is ablative radiation a phenomenon just within the MRIdian community? I include this analysis from Chris Crane's group, and Marcia Rengold was the primary author on this. But this was an MSK experience using mostly fractionated 25 fraction or otherwise 15 fraction CT guided radiotherapy. And if you go to the next, if you advance one, essentially what was shown is that if you go back one, with most patients receiving induction chemotherapy, despite CT guidance, but using significant fractionation, the long-term survival numbers actually were very similar to what we've seen within the VRAY community. And so my interpretation of this is that CT-guided radiotherapy seems to be feasible at an experienced center. Efficacy and safety appear to be similar to MRIdian outcomes. And I think it's really a message that ablative dose at the end of the day, if you give it in a fractionated course or a less fractionated course, does benefit patients with unresectable disease. I think the advantages with MRIdian are that, obviously a 5 fraction course is much more convenient than 25 fractions. And of course, there's not the need to use fiducial markers. Of course, we need additional follow-up on these patients to really tease out, are there differences in terms of safety, et cetera? But these are some initial thoughts. Next slide, please. And then just really quickly, there was mention, of course, of outcomes compared to surgery. And there were really not great data to compare the two, but there was a recent analysis, another one from the MSK group published last year in Annals of Surgical Oncology, that suggests that the outcomes actually could be very similar. And so this was a retrospective study of 200 and so patients with locally advanced disease who received induction chemotherapy. And if you look at the local control rates or local regional failure rates, they actually were no different between the two cohorts, the surgical and ablative radiation cohorts. Survival was worse with radiation therapy, but that probably is just because there were poor prognostic factors inherently in those patients with higher CA19-9 and more advanced disease, et cetera. So I think it's an interesting study that, again, I think points to ablative radiation probably being significantly beneficial, at least from a local control standpoint. Next slide, please. So next steps, you can advance a few here. So of course, the phase 2 SMART trial closed to accrual at the end of last year, and we expect those outcomes to be presented later this year. The primary endpoint was acute grade 3 or higher GI toxicity. So we, of course, are very excited to hopefully see that that the prospective data confirm the retrospective safety data. And of course, prospectively, then the follow-up, I think, studies would be an efficacy endpoint. So is there a difference between ablative versus non-ablative dose? Does ablative radiotherapy add anything in terms of survival compared to chemotherapy alone for advanced disease? Next slide, please. This is a trial that we plan to open here later this year, actually combining SMART with tumor treating fields, the abdomen, looking at again, extending disease control. So the hypothesis here would be after induction chemotherapy and ablative radiation, the majority of patients who progress do so distantly, typically in the liver and peritoneum. So if tumor treating fields can prevent microscopic disease progression or at least delay it, could that lead to improvement in not just progression-free survival, but also overall survival? So this is a study that is looking to do that. Next slide, please. Next slide, please. And just for the sake of time, we can skip this slide. I included some data on reirradiation for pancreas cancer. I'll just show this for reference. Next slide, please. But we have been reirradiating patients with MRIdian, even doses up to 50 gram 5 fractions, which we published as a case report. And then next slide, please. Next slide. And then this is an analysis including pancreas, but other abdominal pelvic tumors that underwent dose-escalated ultra-hypofractionated radiotherapy, published in Advances just at the end of last year. And if you go to the next slide, the early outcomes at least seem to be favorable with no grade 3 or higher toxicity and encouraging at least 1 year tumor control. So obviously much more follow-ups needed for these patients, but I think another expanding opportunity for MR guidance in general. Next slide, please. Next slide, please. We can go to the next slide. And then last but not least, looking at fractionation with MRIdian is something that we've been thinking about, including single fractions. So I would just highlight, we have a feasibility trial of single fraction SABR on MRIdian for various tumor types, both primary and secondary tumors. And this includes pancreas cancer treated at 25 gray in single fraction. And we have treated such patients here with this regimen, and the outcomes have been very good. Next slide, please. So in conclusion, if you want to advance a few, and I'm sorry I ran over time, just the virtual platform just, I think, slowed things down. But I think I think that there's good data to say that MRIdian can safely deliver ablative dose in at least 5 fractions for locally advanced disease. Ablative radiation dose could potentially improve at least local control, and hopefully prospective data in the not too distant future will confirm that overall survival benefits exist as well. And then otherwise, I think, the hope at the end of the day that MRIdian offers patients, I see this every day, and I'm sure many in the audience do as well, where now you have a tool that can, go above and beyond what is considered to be possible. And we've seen some tremendous outcomes. So I think hope is a tremendous, other benefit of MRIdian. Next slide, please. And to drive home that point, this is one of our patients we treated with 15.5, and her daughter sent me an email, just sort of unsolicited, and said that mom's been doing better than ever. Her pain has been greatly improved. She's eating better, feeling well. Next, we can advance. They went to the week after she was treated. She went to Hawaii, hiked Diamond Head Crater, and really, I think was inspired that she had such a good outcome when she was told before coming here that there were no other options and she should go to hospice. Next slide. So this is, it certainly takes a team to do what we do. And this is our team here. So I wanted to acknowledge them. And with that, I think the last slide is the end. So with that, I'm sorry for running over, and thanks for the opportunity to share.
Thank you very much, Mike. That was a fantastic overview. And thanks for your patience with the platform there. Are you able to join us later on for Q&A, or would you rather do that at this stage?
I actually have an adaptive pancreas patient I have to run to here soon, but if I can stick around for a couple of questions now if there are
That
any.
would be great. So thank you. So any questions in the room before we start? Luis.
I'm Luis Varela from Spain. I would like to ask you, we can treat pancreas with 1 fraction, 3, 4, 5, or maybe 8. But for you, will be the minimum equivalent dose to be a good treatment or an ablative treatment for pancreas tumor? You hear me or the question?
I heard I think it was a question about fractionation, but I missed part of it.
Okay, we can treat pancreas with 1 fraction, 3, 4, 5, or maybe 8. But equivalent dose, which one you think is the minimum to treat with an ablative dose for a pancreas tumor?
Yeah, that's a good question. I mean, I don't think we have a good sense of exactly what is the quote unquote right BED. And there's still, I don't think there's a consensus about necessarily what is an ablative dose, whether that's 100 gray or if that's 70 gray or whatnot. I think, the doses that we've been giving with 100 gray BED and 5 fractions have been well tolerated. So I think that the trials moving forward probably will predominantly focus on that, just based on the safety that's been demonstrated so far. But a single fraction 25 gray, is that from a BED standpoint better or worse than 50 and 5? Those data I don't think are there. There's been a little bit of data I'm aware of from the Stanford group that compared single fraction versus multi-fraction. And at least in those analyses, there was really no significant difference in local control, but the toxicities were worse with single fraction. But again, that was not with MR guidance. So I think there's opportunity to explore, whether we can safely deliver a single fraction, or at least reduce GI toxicities with MR guidance in that regard.
The threshold in the Rudra paper was a BED 10 of 70 gray, wasn't it? And above that seemed to be associated with the better outcomes.
It was, and also in the MD Anderson analysis as well. So,
my question was related. So you did cover this, did touch on this in your talk, but when you were talking about minimum dose to the GTV, it's something that when we plan pancreas patients, we think about a lot. Do you have a feeling for whether there's a threshold of a kind of acceptable GTV percentage coverage with the prescription isodose that you'll either accept or send back for further optimization, or is it really not possible to systematize it as yet?
I don't think those data are there to say one way or another, to be honest with you. We do look, and I do look at my minimum dose, but in part it's due to the proximity of your GI OARs and the overlap of the PRV with your target. So I do look at it. To be honest with you, don't prescribe, a minimum dose coverage. I do look at obviously the dose to the rest of the tumor, the mean dose, and also what the hotspots are. The other question too is minimum dose significant in the context of cumulative dose adapted over 5 fractions or whatever you're prescribing? And those are answers we just don't have yet.
Thank you. Anna Brunzil.
Thank you, Mike, for the very nice presentation. I was wondering, do you think there will be a role for SBRT prior to surgery, for example, in the borderline resectable pancreatic cancer cases?
I think the jury's still out, to be honest with you, about SBRT for borderline resectable, at least compared to chemotherapy alone. And many of you are familiar with the Alliance A005, I always forget the number, but there is the Alliance Borderline Randomized Trial of FOLFIRINOX plus or minus SBRT. And Joe Harmon and I wrote the radiation protocol for the trial. That trial has been, I think, interpreted as there's no role for radiation therapy, but I would interpret it differently in that, the radiation arm met the definition of futility just based off of, if there were 2 more patients that went to surgery, the trial, that arm would not have been closed. And so the question that we're looking at now is why did more patients not go to surgery in that arm? And I think there's a lot of potential explanations, but we're actively looking at that now. Whether there is a benefit at least of ablative versus non-ablative radiation for those patients, I'm not quite sure, especially if, for a lot of borderline patients, at least at our institution, regardless of if there's radiographic response or not, the surgeon is planning to take them to the OR. So I think in that case, probably less of a benefit with ablative RT. I think for those cases that are more on the fence, and who may not go to surgery, I think the dose escalation there, using SBRT probably does matter more.
Great. Okay. Well, I think in the interest of time, we'll move on to the next speaker, because to my right, I can feel like a coiled spring. It's Dr. Stephanie Corradini, who leads the MR-guided radiotherapy program at University Hospital in Munich. And Stephanie has a particular interest in both stereotactic radiation and, wait for it, brachy for liver tumors. So, Stephanie, I'm hoping for some controversy.
Yes.
I'll hand over to you. Thank you.
Thank you very much for the invitation. Let's see. Yes. I'm going to speak about ablative radiotherapy of liver tumors and how we approach that at LMU in Munich. I'm the attending physician taking care of both the MR Linac system and brachytherapy. That's why basically I do both of it. If we speak about liver tumors in our institution, we always really like to talk about the toolbox, which is different techniques and modalities which we use for the treatment of liver tumors. So first of all, usually in our tumor boards, we rule, or the first option is actually surgery, so that's always discussed with our surgeons. And then, of course, liver, it's a big domain of the interventional radiologists, as they have a lot of thermal ablation techniques or also other techniques. However, in our department, in the Department of Radiation Oncology, we actually have also multiple options how we can treat liver cancer. So we have a basic Linac, as I say, or we have the advanced MR Linac system, and we have brachytherapy. And for liver, we mainly focus on MR guidance or brachytherapy. So if you have a look at our case mix on the MRIdian system, you can see that the proportion of abdominal targets is really high. So liver, pancreas, lymph nodes, and abdominal lesions are a huge proportion, and of course also lung cancer. And when we have a look at the first 3 months of this year, you can see that at the MRIdian we treated 18 patients and applied 44 fractions to treat 20 lesions. So that's a mean number of 2.4 fractions per patient, which you can say it's not so much actually, right? Usually you do 3 or 5 or also 8 fractions sometimes. However, we have this very large experience from brachytherapy, where we always do a single fraction. That's why we also apply this knowledge to the MRIdian. And you see that at the same time, we treated nearly 40 patients with brachytherapy. And there we also treat more lesions per intervention. So it was over 80. So I want to share with you when and why do we use the MRIdian system for liver. And of course, first of all, we really love the imaging of the MR. You can see here, that's an example, it's actually the same patient, how very nicely you see it on the MRI, even without contrast. And on the CT, it's not so easy to see. If you switch very quickly, you can see it on the CT, but not without having the MRI close to it. Usually we do the simulation without contrast, and I would say that about 80% of all lesions we can visualize very well in the MRI trophy sequence. And in all other cases, we apply a contrast agent, this hepatospecific contrast agent, where it's really easy because usually you want to use the very late phase. So from the logistics, it's easy. You can apply it, then the patient goes inside the vault, and then you start scanning after 10 minutes. That's optimal. Here is an example. Now, if you see it like this, it's like you don't really see a liver lesion. But then if you apply the contrast, you can see how nicely also with this sequences you can detect the liver lesions and then perform target delineation. Then the other big advances of the system is obviously the automated tumor tracking. As you can see here, this lesion was very close to the heart, so there this gating function obviously is really helpful to keep your margins also small. The online adaptation, this of course is especially helpful in lesions which are close to organs at risk. So usually it's bowel or stomach, and there you can, like in this example, you see that the bowel was not so close to our target during simulation, but then on the following fractions, it moved towards our target, so we really had to optimize to get the dose down in the bowel. And we also published our first experience of a few cases and could show that with the adaptation, we can improve the target coverage, but also significantly reduce the dose to organs at risk. We have a few studies going on regarding the MR-guided radiotherapy. For liver, currently we have 2. One is the single-shot liver study, which I'm going to share. It's for 1 to 3 liver lesions. which are actually not close to organs at risk. And the primary endpoint is local control. By now we have treated, actually now it's 20 patients, and I can show you here one case. We prescribed 28 gray to the PTV on the 80% isodose. That's in the GTV you have usually a mean dose of above 33 gray. And you can see that it's also sometimes able to track very, very small lesions. So that's the before and after image. You can see also there was a second lesion very close to the ribs. We treated this lesion in 3 fractions. So here's a case, typical case, colorectal carcinoma, had chemotherapy, then first diagnosis of liver metastases in 21. He underwent surgery, a left hemihepatectomy, and then in February he had a new liver lesion. It was a single lesion. It was perfectly for a single fraction, so you can see that was our treatment plan. And to give you more information about how we plan this. So we used not so many beams, and the segments also, we tried to keep the number of MUs small so that the treatment does not last very long. And you can see that we applied this entire treatment in this patient was 47 minutes. So I think that's really nice. Here you see the follow-up. Basically, it disappeared, but then he also had a new lesion. But we see that very frequently. So he had a new lesion. This one is very close to the duodenum, so I think we do more fractionated treatment. Another case, that was a patient with sarcoma. She had a very long history, so from 2012 already. So she had also had multiple liver treatments before, and then she presented with these 2 liver lesions, as you see in the MRI image. And here we actually performed a single fraction treatment on both. We're using 1 plan and 1 isocenter. And that's where I'm really looking forward to the new upgrade, because then we can track both of them. As you can see here, we track the whole liver. You can also do that, of course. And this was also very nice. In 42 minutes, we treated both lesions in 1 fraction. There's another study from Heidelberg, actually, where we will join. It's a prospective study. It will randomize between MR-guided SBRT and the ITV-based approach if you can reach a BD of 100. And in all other cases where you cannot go so high with the dose because you're, for example, close to organ at risk, then there's the other arm which will be only with MR guidance. So now I have 2 special cases also for you that you can see how we decide in the clinic. I think you could also decide to do it differently, and I just want to share how we did in these cases. So one patient is a hepatocellular carcinoma, very large tumor with a BCLC stage with portal vein invasion. He then had immunotherapy and he had a remission, and then he had to stop, and then he came to our department with this recurrence, you can say hypervascular tumor in the arterial phase, and then a washout in the venous phase. And we treated him actually first with brachytherapy. There we apply actually only 15 gray to the tumor surrounding structures, but the mean doses are very high, so here over 50 gray. Here we had to choose a very angulated way because it was all in the liver dome, so maybe there was also a bit of issue with respiration. However, he had a small remaining hypervascularization on the follow-up, so we decided to treat him with MR guidance SBRT. Basically, it's a re-irradiation. We chose a dose of 3 times 12.5 to the 65% isodose. And here, that was the follow-up recently, last month, and now he has a complete remission. Another case, also hepatocellular carcinoma, 54-year-old patient. That's actually a very special patient story. The first diagnosis was in 2017. He started with sorafenib, and then he had a brain metastasis. So he got surgery, then he received also a post-op SBRT to his brain, a resection cavity, and started nivolumab. Then in 2019, at that time, actually, we did not have the MR Linac system ready. So he presented with 2 lesions in the liver, where we then also applied brachytherapy. As you see, we really like to do that. And so we also treated 2 at one time. So that's why we chose, in this case, brachytherapy, because with the other techniques, it would have been a lot of fractions. And then the oncologist called me and was like, oh, he received now like 47 cycles of nivolumab. That's a long period. And he has a few lymph nodes. Could you please have a look? And it's like a video scrolling down. He said it's like 2 lymph nodes, but actually we then had a look at the images, and it was 9 lymph nodes altogether. So what we really did in this case, we did a SBRT of all of these lymph nodes because he had this very long history that was an oligoprogression. I chose a bit a lower dose of 5 times 5 gray, but also HCCs are very radiosensitive. And now, 2 years later, patient is stable, and we only have 2 very small residual lymph nodes, so that's really an excellent result. So taken together, we have this toolbox, which we have different techniques. Usually we discuss a lot in our tumor boards, especially with the surgeons, and then regarding the other techniques, it's on a case-by-case basis. Frequently, you have also to take into consideration the patient preferences. Do they like an intervention or do they not? Or also the comorbidities. Sometimes they're not even, they cannot undergo surgery because they have anticoagulants or whatever. So there is a lot of points you have to consider. Very quick side note, we have an Astro course planned for in-room MRI, guided radiotherapy. It's for RTTs, medical oncologists, and physicists. So if you're interested, you can sign up on the Astro homepage. Thank you very much for your attention. Sorry?
Have a seat on the chair. We'll do some questions.
Now or later?
Yeah, now. We're not going to let you escape. Does it feel as though you're on the spot, sat there by yourself?
I have to, like at school.
Okay, thank you. That was a lovely presentation. Are there any questions from the room? And are there any questions that have come in online? Any questions online, Sarah? No. Okay. I mean, the liver is, as you say, a bit of a battlefield when it comes to the interventional radiologists as well. And I forget which journal it was in, PRO maybe, but there was an article a couple of years ago that kind of acknowledged this, that who do we fight for on the battlefield of the tumour board was the subheading, specifically about HCC rather than metastases, but I think it applies to metastases. Does your centre do CERT as well, Y90? And is that part of the mix? So how on earth do you choose between all of these? What's the actual physical environment that you have that enables best selection?
We have a very strong, actually, interventional radiology, but CERT for us is never a competitor, because they only apply it in very advanced stages. So if you have like 6, 10, 20 metastases, so that's actually never really comes never into place when we decide between other local ablative techniques. So that's more for also taste, I would say, except in HCC. It's more like more advanced stages. Otherwise, we always have a very strong and very collaborative collaboration with the surgeons. And for us, it's never like on a battlefield and say which technique you do. It's more like we have a lot of cases, so maybe that makes it also easier. And then you decide if surgery is possible or not. That's always question number one. And then for the other lesions, we then decide what is a thermal ablation feasible or not. And actually, thermal ablation is not feasible in so many cases. And these are all the cases who can get treated by radiotherapy. Mm. And there are so many limitations for thermal ablation. And that's where we then come into play.
Yeah, I mean, I think centers with big volumes of patients have found this. You know, we've found that with HCC, that actually the patients that I get asked to treat with SBRT are just the ones that nobody else can treat. And their only other alternative then is systemic therapy. And if all we do is delay that by 6 months or a year, then that's actually a good outcome. When it comes to brachytherapy, just again thinking about the difference between metastases and HCC and tumor vascularity, HCC for the uninitiated or those who don't remember being typically much more vascular tumors than metastases. Do you think that influences local control after brachy versus, you know, ultra hypofractionated brachy versus SBRT? Is that part of the thinking or not really?
Not really, but for taste, that's a very important point, because the non-hypervascular tumors do usually not respond well to TACE. So I think they would need additional local ablation. Actually, we'll now plan a study where we then add SBRT in the bridging before transplant, if they're non-hypervascular. But yes, that's like the points. We still have to figure out which technique is the best for which patient also.
Are the vascular tumors more likely to bleed after brachy? Is that a consideration?
Not really, actually, because we also fill the puncture tract with some gel foam, and then what we know is that patients with cirrhosis, they have a higher risk for bleeding if you do a brachytherapy. That's how it is. But of course, you have to see how the blood values are and then decide if you can do it or even not. And that's when then we decide it's too risky, then we prefer like a MR-guided radiotherapy.
Sure, okay,
Of course,
lovely.
it's non-invasive and very easy to do.
Okay, any more questions for Stephanie? Yes.
Stephanie, just a fantastic talk. It's just a question about the point you were just making, is that with MRI guided, is there a Child's Pugh score you're now comfortable that maybe you were uncomfortable with previously with MRI guided, that maybe, or do you have a limit in terms of liver function that that now MRI guided has opened the door for you that might have been not possible previously, or how do you think about that?
Not really. We're very like a 7-point score is our limit, I would say. Otherwise, it's very, it depends on the size of the lesion and how much the liver, the healthy liver dose is. But I guess we still keep now to this traditional values on when you do it and when you don't. But yes, maybe that's also something we should explore, to go more into the elevated child scores, but be more strict with the liver exposure.
It comes back to what Drew said earlier on, ALARA, ALARA, ALARA.
Yes.
And that's particularly relevant to HCC. The proton data suggests that the low dose bath to the normal, the cirrhotic liver, is actually the thing that can limit life expectancy. And so again, going back to what Drew said about R cubed, and the smaller the irradiated volume, the less therefore the low dose bath to the rest of the liver. So one of the areas I'm most excited about with MR guided radiotherapy for the liver is HCC. Actually, not so much for dose escalation, but for normal tissue minimization, if that makes sense. And our experience, not at GenesisCare, but within the public sector that I also work in, is that anything above Child-Pugh A6 is pretty high risk. And actually, even the difference between A5 and A6, there does seem to be a difference in the risk of decompensation 6 to 12 months later. You have to be really careful with these patients.
Yes.
But it's also a fantastically rewarding disease to treat because it's so radiosensitive.
Yes, that's the other
great
point.
tumor control. Thank you, Stephanie. Thank
Thanks
you very
a lot.
much. Okay, so the next talk is from my friend and colleague Andy Geyer. Andy's a leading UK-based GI oncologist. He's got an interest in functional imaging and immunotherapy combinations, and he's had a huge impact on the development of our MR Linac service over the last 2 years. Andy has pre-recorded a talk, and all I'm going to say is that I think it has a local flavour. We'll see if you can decode Andy's joke. Cheers.
Good afternoon, and many thanks for asking me to speak today at this MR Linac symposium. I'm just going to say a few words about the role of MR Linac in GI cancers. This could be for a primary pancreatic tumour, primary liver tumours such as hepatocellular carcinoma or cholangiocarcinoma, for the treatment of abdominal or pelvic nodal recurrence, liver oligometastases or oligoprogression, and then importantly reirradiation SABR. The advantages of MR Linac over other platforms are the excellent soft tissue definition on the MR and contrast, our ability to adapt the contours of the GTV and the organs at risk for daily anatomy, to be able to re-optimize the plan on a fraction by fraction basis, to deliver gated treatment to the patient, and all of these advantages lead to enable us to have the confidence to reduce our margins, and we use a 3mm PTV margin, which consequentially reduces PTV volume. This gives us more control for challenging cases, and we're treating patients on the oligometastatic spectrum by and large. And what might we gain by treating these patients? Well, if we look at the spectrum, the oligometastatic spectrum, from potentially curative patients with primary localized disease all the way down to palliative patients with disseminated polymetastatic disease, we're treating somewhere in the middle here, and a proportion of these patients, importantly, by the use of local ablative therapy, will shift leftwards down to be potentially cured, and a proportion, unfortunately, won't be cured and will shift right towards palliative treatment, which is where oligoprogression sits on that spectrum as well. This slide illustrates the potential volume in PTV by using a gated MRL solution. The first column shows the varying tumour sizes. If we assume for the purposes of this that the tumour is a cuboid, we have the tumour size here down up to 10 centimetres on the column 1. Column 2 shows the corresponding GTV, the GTV volume up to 1000 cc's for a 10 centimetre tumour. And then the PTV volume, if we use a 3mm PTV margin, you can see that a 1 centimetre GTV becomes a 1 cc GTV becomes a 4 cc PTV. Correspondingly, 1000 cc becomes 1191. If we don't use gating, if we treat patients in free breathe with 4D CT planning and create an internal target volume, the corresponding increase in planning target volume can be huge, as you can see here, 358% for a 1 centimetre tumour, 33% for a 10 centimetre tumour, but the actual volume increase there is large, from 1200 cc's up to almost 1600. So the potential volume of normal tissue that we can reduce in the high dose region is very significant, and that becomes even more significant in the setting of irradiation. So let me get on with the case presentations. This is a solitary liver tumour, but not your average solitary liver tumour. It's a 14 centimetre HCC spanning 3 liver segments in a non-cirrhotic liver. The patient's Hep B, Hep C negative. He had 5 cycles of TACE with stable disease and was planned for an extended right hepatectomy following PVE and was referred for SABR as bridging therapy. There was a long discussion at MDT regarding the pros and the cons of MR Linac versus protons. We decided in the end for MR Linac due to motion management, the improved image guidance and the advantages of daily adaptation, but really there are strong arguments for either approach in this case, and we planned him for bridging treatment of 30 gray and 5 fractions on the MR Linac. This is the planning MR scan, the 0.35T MR scan here with PrimaVist enhancement. You can see the volume delineation was made so easy with the PrimaVist enhancement. You can see as well on the sagittal and the coronal sections, but a large volume. Here's the treatment plan for 30 and 5. The PTV was over 1500 cc's, and this was with just the 3mm PTV margin and respiratory gating. This slide shows the cine footage. We're tracking the whole liver here. The patients are now holding their breath, and the PTV is moving in and out of the region of interest here, which is circled in yellow. The patient can see the screen, and when they take a breath in, they will be asked to shift the red line, the red circle essentially within the yellow circle, and at that point the machine will beam on. There we go, it's beaming on now. The patient can breath hold for as long as they can manage, and the machine will automatically beam off when the PTV moves outside of the region of interest. This is a very good breath hold. There we are. So let's move on from one liver tumour rather, to 2. This is a reirradiation case. Now within GenesisCare in the UK, we've had a little look at the number of patients that we've been treating who've had previous radiotherapy, and the proportion of SABR patients that we treat, almost 1 in 3 of those have had previous radiotherapy, and of our SABR patients, 20% of them, so 1 in 5, have actually had previous SABR. This is this abstract that we presented at another meeting, shows the 2 things. First of all, that liver irradiation using conventional techniques with internal target volumes is very challenging due to the cumulative normal liver dose. So this patient, who's a 50-year-old lady with a diagnosis of metastatic breast cancer, she had a single solitary liver metastasis planned and treated with 45 gray and 3 fractions. Again, the CTV PTV margin here 0.3. With conventional SABR, it's more like 1.5 with an ITV, and that can give a quadrupling of the PTV volume. That's not so important for the primary treatment, but the patient represented 6 months later with 2 new lesions in the left lobe over here, close to the esophagus, and SABR treatment was recommended to both of these, again to a dose of 45 in 3. And what we can see here is that with the 3mm expansion, we're able to achieve a far lower proportion of normal liver irradiated within the high dose. The actual volume is hidden beneath my face on this slide, but there's a significant volume reduction, round about 300%, as I showed you on the previous slide. So moving up now to three liver tumours. This is the case of a 43-year-old female with a sigmoid adenocarcinoma and synchronous liver metastases, MMR proficient, KRAS mutant. She had some chemotherapy, then a right hepatectomy with a portal vein embolization, prior, completed her chemo and then underwent anterior resection to remove the primary, 12-month progression-free survival, and then developed 3 new liver metastases in the remnant liver and small volume right-sided pulmonary metastases. We gave SABR, 60 gray in 5 fractions to the liver metastases. She had radiofrequency ablation to the pulmonary metastases and then went on to complete further chemotherapy treatment. Here's the SABR treatment plan for 3 METs, you can see here in the remnant liver. And we managed to get great coverage here. Again, with the advantage of MRL gating and daily adaptation and plan optimization, we've got really good coverage, almost 90% at 60 gray, with all the organs at risk in tolerance. How high can we go? Well, here's a patient. We treated 5 liver metastases on a 72-year-old male who had a right hemicolectomy for cecal adenocarcinoma back in 2019, very high nodal burden, with synchronous liver metastases and some portal nodes. He had chemotherapy with a good response and then stable disease over about a 2-year period, then began to progress in 2021. Irinotecan was reintroduced. He responded and then started to progress again and was referred for SABR to the liver. Here's the volume delineation on the ViewRay MR planning scan. Again, PrimaVist enhancement. You can see 1, 2, 3, 4 of the liver metastases, 4 of the 5 you can see on this slide. And here on the plan you can see all 5, 2 inferiorly and 3 superiorly. Good coverage. Again, on the plan treatment comparison, almost 90%. The patient was planned for 45 in 5. That was the highest dose we could get, given there are 5 metastases scattered throughout the liver. How about 6? Here's a case of a 75-year-old female with multifocal hepatocellular carcinoma with multiple small lesions, 2 to 3 centimeters. She had 2 rounds of TACE with a poor response and was referred for SABR in consideration of systemic therapy. Again, small lesions, PrimaVist enhanced MRI that we use for planning. You can see how easy it is to delineate the HCCs, because even on an arterial phase CT with conventional CT planning, it's challenging to say the least. And here's the treatment plan. 6 lesions. 40 gray in 5 fractions. We've dropped the dose because it's HCC, 6 lesions, cirrhotic liver, so we need to take care given that background, but really good coverage here at 40 in 5. So moving away from the liver now to pancreatic cancer, here's a 55-year-old male with unusual acinar cell carcinoma with a solitary liver metastasis. The patient has a BRCA mutation. He had FOLFIRINOX up front, MRL to the liver met and the primary pancreatic tumour in 2021, and then had isolated progression in the distal pancreas earlier this year and was re-irradiated and is now being considered for a laparoscopy. So here's the first treatment plan for the liver met, 50 gray in 5 fractions. He also had the pancreas treated at the same time, 40 in 5. Those were delivered sequentially. And here's the re-irradiation plan from last September, 30 gray in 5, full overlap from the previous treatment field. But we achieved this, and with very reasonable coverage here at 30 gray. Here's some online cine footage of a pancreas tumour. Again, same principle as with the liver. The patient will breathe, they'll be looking at the screen, and they'll use their breathing control to pop the PTV within the yellow region of interest. There it is now. And they can take a breath out whenever they like, and the machine will automatically beam off. And as soon as they're ready, they can do the same again. So last case now is a 38-year-old female with an adenocarcinoma of unknown primary, presenting with a mass of celiac nodes. An interesting genetic profile. She's MMR deficient with a high tumour mutational burden and also a BRAF mutation. No comorbidities, no significant family history. She had FOLFIRINOX from 2018 to 19 with a good partial response, but it was very poorly tolerated with a lot of toxicity. And we switched her to nivolumab in January 2019. She had that for a year with ongoing response in the nodes with no new sites of disease. So in March of 2020, we gave SABRE to these retroperitoneal nodes. Here's the volume on the planning MR scan. You can see it there on the sagittal. And here's the treatment plan. 50 gray and 5 fractions to the retroperitoneal nodes. She responded very well. In fact, she had a complete metabolic response after the treatment, continued her nivolumab. There was an oligoprogressive right common iliac node in January of last year. We treated that with 14/5, again a complete metabolic response, continued her nivolumab, and then earlier this year she developed another oligoprogressive area in the left adrenal gland, which was very close to the previously irradiated area, partial overlap, and we've managed to retreat that to 14/5 as well. This shows the partial overlap. So this is the adrenal metastasis. You can see on the volume delineation just here, very close to the previously irradiated celiac nodes, close to the stomach, and we've been able to deliver 14/5 safely. Thank you very much indeed for allowing me to present. Good afternoon.
So Andy, I think, can't join us online for questions. I believe Escalata has one question. Yes?
Oh, yeah, sorry.
Thank you. James, could we consider some indication of this technology for colorectal carcinoma or not yet? Or rectal.
In what kind of clinical setting? In the liver or?
No, in the primary.
Well, yes, I think very possibly. So short course radiotherapy, as you know, is becoming more and more prevalent as opposed to chemoradiation. So that's 25 gray and 5 fractions typically, and we're in Oxford developing a protocol that will enable us to implement that on MRIdian for patients, for example, with an inoperable pelvic sidewall node, so a node outside the mesorectal fascia, and giving a simultaneous integrated boost to that. And also looking to see whether there's any scope to dose escalate to the primary tumour in the setting of organ preservation. So, again, many elderly patients, for example, with T1, T2 tumours who don't really want an anterior resection and are looking at organ preservation could perhaps get better outcomes with dose escalation. And I think the advantage of MR guidance in that situation is that you're better able to delineate rectal GTV separately from the whole wall of the rectum, and also adapt, obviously, for any interfraction motion. So I definitely think there's scope for that. And other centres, I don't know whether Stephanie's doing it, but I know that Gemelli have certainly gone quite a long way down that road already. Okay, we're short of time, so we're going to move on to the last GI talk now, which is given by Derya Usul. Derya is the lead MR Linac physicist at our London centre. Derya has extensive expertise in SABRE planning and optimising MR Linac workflows, and it's that topic that he's going to be covering this afternoon.
Good afternoon. I cannot see my slide at the moment.
So, Derya,
Yes.
you're not able to advance your own slides this afternoon, so if you could call out next slide, please, after each slide, then the staff here will move through.
Of course. Good afternoon. I'm Dr. Derya Usul, the lead MR Linac physicist at GenesisCare Cromwell in London. I'm glad for this opportunity, and I'm going to present our MR Linac patient workflow and GI case data. Next slide, please. This is our MR Linac system in London. Next slide, please. Sorry, currently I cannot see my slide. Yes, now I can. We have two identical V-Ray MRIdian MR Linac systems in the UK. First was installed and commissioned in December 2019 in London, in Oxford, sorry. And Oxford Clinic has 10 years partnership with University of Oxford. The second one, London Clinic, went live in July 2021. And there's a third one in Guildford. It's coming next summer, hopefully. V-Ray MRIdian system uses low magnetic field, 0.35 Tesla, and single energy 6 MV FFF. It operates fully adaptive treatments, and we are using 8 frames per second cine imaging, so it allows us to track and gating the tumors. There will be a major upgrade coming A3i this year. We are using Siemens CT on both centers, and it has Vision RTM for the gating options, which we are not using for the MRL service, and 7 centimeter bore. We are not using any heart immobilization system. We are using torso and head and neck coils. There will be brain and SRS coils coming with the A3i upgrade. Next slide, please. This is a okay. MDT approach. We have an exclusive team dedicated to the MRL service. We have 22 doctors covering the on-site treatments and doing the contouring, planning, all the clinical works. And we have 2 PhD medical physicists and 4 dosimetrists dedicated for the MRL service with 8 MRL radiographers. We have a credentialing process. So we have a comprehensive certification to accept referrals from any doctor, and everybody who is working with the treatment, MRL treatments, needs to complete their competencies. So this is a required certification to treat patients in the GC UK. And on each treatment, we have at least 1 medical doctor, 2 radiographers, and 1 on-site checker, either physicist or a dosimetrist in the center for the treatment. Next slide, please. This is the workflow. So we have very specialized workflow for each case. We have a SAVOR SPR, the advisory team, and in this team, all the referrals are being assessed for the suitability for the treatments. And all the required medical documents are being reviewed multiple times by the entire MRL team. Consultants are responsible to peer review for each case at various steps for the contouring and planning. And dosimetry team is responsible for the contouring and planning. Physics team is responsible for plan checking and quality assurance, and radiographers for the initial and final checks during this patient assessment process. So we can call our system as safe, robust, and high quality. It is safe because each case is checked multiple times by various staff until the treatment starts. No treatment unless entirely confident. Only competent staff takes place in the process. Everything is written, and we are having internal audits to keep this quality. And we have a no error policy. Next slide, please. Those are the work charts for the treatment planning and the adaptive treatments. So this is valid for all GI cases as well as the other cases. So when we have the referral, this referral is assessed in the SAVOR MDT team. And when we have the simulation, the contouring process is peer reviewed by the second oncologist. And the planning process is also peer reviewed by the same team. Then we have the plan checking process, and all the cases are being assessed with the patient QA before the treatment. Then radiographers control all the documentation, and then treatment is can be started. Adaptive treatment also, for each case, we have adaptive treatment approach, and on each fraction we have adaptive MR imaging. Then we check the electron density, we correct it, we recontour the targets and organs at risk. Then these contours are peer reviewed by the second doctor or the onset checker. Then adaptive dose optimization, we recreate the dose distribution based on the needs of the day. Then this plan is peer reviewed and by the onset checker or the second doctor. Then the onset checking process has been assessed, and the adaptive patient QA internal V-Ray independent monitor unit check is being used. Then we always control the target, we always follow it, we never treat if we cannot see or follow, and then treatment starts. Next slide, please. We have a troubleshooting process because this is a highly complex treatment and it takes longer time. We have written policies to cover possible scenarios and routine audits to maintain the outstanding quality. If the patient's anatomy changes during the treatment, we try to eliminate the problem or start over if the impact is significant. Or if the target moves out, we redo the simulation and apply the cost shifts to keep the target as it's required. If the patient feels unwell or has any comment, we stop the treatment and only continue once the patient is entirely comfortable. Next slide, please. And GI treatments data. Next slide, please. Yes. We have treated more than 500 patients, and that means more than 2,500 fractions. This is weighted in January. And if we see the treatment site breakdown, after prostate, all the major sites are pancreas, liver, and abdominal for the GI cases. So GI cases are around 40% of our total patient flow. And we have an increase in patient referral performance. If you can check the below chart, it's increasing every day. Next slide, please. GCU case focus on GI MRL. We believe that MRL is a breakthrough technology and it is under continuous development. We can say previously impossible treatments are coming through day by day. And for gastrointestinal cases, we mainly focus on pancreas, liver, and abdominal metastasis. With the MRL technology, we offer fewer fractions and higher dose with improved control and reduced toxicity because we can separate the organs at risk better, and we can just recreate the dose distribution every day. And if we can see the below table, the margins are significantly smaller than the conventional treatment Linacs, because in some cases, if we see CTV margin might be zero. So from GTV to PTV, we could only have 3 millimeter margin safely. Of course, this is case by case. It depends. And we can treat up to 50 to 60 grays in 5 fraction. And that depends on if we have a previous treatment or not. On the right side, we can have a look on the pancreas MRL cases. How much dose do we apply commonly? And for the pancreas, the majority is 40 gray, as you can see, but there are some 9% cases which we applied more than 40 gray. For liver cases, again, the majority of the doses are about 40 to 50 gray, and we have some 14% cases we could apply more than 50 gray based on the necessity. And abdominal MRL cases, majority again, 40 gray. So usually it is 8 gray per fraction, we can say. Next slide, please. The time required to prepare the treatments with the highest quality and error-free is determined as 10 working days by our clinic, because as you could see the chart, we have many pause and checkpoints, and we want to establish high quality. And as you can see, all the cases are more or less takes 14 days, which means 10 working days from referral to treatment. And this graph shows us that we have achieved this goal. On the right side, we can see the distribution per task on adaptive treatments. As you can remember from the chart, we have setup imaging, and it takes approximately 2 to 3 minutes. And organ at risk contouring for pancreas and liver cases takes up to 15 minutes. And optimization is about 5 minutes. Patient QA takes around 2 minutes. And the treatment itself, again, takes 15 minutes. And we always analyze this data to maintain the quality and improve the service. And with the upgrade, with the upcoming A3i upgrade, these organs at risk contouring will be much faster, and we will be seeing the treatment will be reduced from 60 minutes to 40 minutes, I believe. Next slide, please. Next slide, please. And this is the quality assurance. We always control the quality before applying the treatments to the patients, and on each day also. So before the treatments, we are using ARC checks. And as you can see on both charts, we have hundreds of patients on this list, and there is almost no case less than 95% accuracy. Next slide, please. And this is the adaptive treatment gamma analysis results. Again, there's no case with less than 95% accuracy. We always pay attention to the quality, and if we hesitate, we don't apply the treatment. Next slide, please. Yes, thank you very much for listening to me.
Thank you, Daria. Any questions for Daria? Perfect. So that's the end of the GI session. Thanks for engaging with a nice set of talks.